Thank you, everyone, so much for joining us. My name is Kristin Bendikson, and I am one of the fertility specialists at Kindbody. I practice in Los Angeles and LA. We have a couple of offices that all the doctors kind of work at both of them, and in both Century City and Santa Monica. But I practiced for a long time, and I did my training in New York. I did my fellowship at Cornell. I was in Boston for residency at Harvard. So I've been all around this country. So it is really so fun to see everyone log in from everywhere. In addition to my role as a reproductive endocrinologist, I also serve as one of the senior vice presidents of this company in clinical development. So it's really just so incredible to see what we're doing and how we're impacting patients' lives and growing all over this country and helping so many people. It's just so special. So it's really exciting. So thank you all for being here tonight. So tonight we're really going to just kind of go back to the basics. So first of all, we'd really like to introduce Kindbody to you. So next slide, please. So at Kindbody, we are truly on a mission, and that mission is to make reproductive health care and fertility care accessible for all people. And so we serve our patients directly. So patients can come to us if they don't have any fertility insurance. They can come to us if they do have some insurance already through their regular insurance providers, or they have fertility insurance through specialty fertility providers. And then we also provide insurance on our own. So we work with employers and we actually provide fertility and family building benefits to their employees, which is really exciting and special for us. Next slide. So what do we do at Kindbody? Well, we do lots of things, but we specialize in fertility. And so we do fertility consults for men and women. We have virtual consultations, in-office consultations with board certified fertility specialists. We do egg freezing, sperm freezing, embryo freezing. We do all sorts of different types of fertility care, including IUIs, which stands for intrauterine insemination, and IVF, which stands for in vitro fertilization. We help patients who need to use donor eggs and donor sperm. We do genetic testing for our patients. We have at-home fertility tests that we provide for patients who are maybe not ready to come into the office, but still want to learn a little bit about their fertility. And in addition to that, we really think about the patients from a 360 view, and we want to make sure that they are supported. And so we have specialized support for our LGBTQ patient population, for those patients needing donor gametes. And by gametes, I just mean donor eggs and donor sperm or donor embryos, or those that need to use a surrogate to carry a pregnancy. We also have lots of different ways that we can support our patients in terms of wellness healthcare. We have nutritionists that we work with that specialize in different disorders that are related to reproduction, and then actually just can help any of our patients lose weight, because that is a factor in fertility. And we have lots of support with mental health, and that's incredibly important. And I'll talk about that a little bit later in this talk about why it's so needed. Next slide. So let's go to the 101 of fertility. So what are the basic building blocks of fertility? So we need sperm, we need eggs, and we need a uterus to have a baby. Although I think scientists are working pretty hard to figure out ways where they can actually have babies that are born in artificial uteruses, but we are not quite there yet. So we definitely need a uterus. So next slide. So what do we need to know? One of the most important things that you need to know is you always have to be thinking about age. And this is much more important for women than for men. Men have sperm that are being created all of the time, where for women, women are born with a set number of eggs. And so for women, the age really matters. So next slide, please. So if we think about it in terms of what happens for women, whereas men have sperm being created all the time, we're born with about 2 million eggs. And by the time a woman goes through her first period, we have about 300 to 400,000 eggs. So you have lost the majority of your eggs by the time you have your first period. And then throughout the rest of your life, right, you're going to be losing lots and lots of eggs every month. And it makes sense because if you have 400,000 eggs at the time of your first period, you're going to have 0 eggs when you go through menopause, which is 50. And so between the ages of 13 and 50, you're not having 400,000 periods. So that tells you right then and there that you're losing multiple eggs every month. And I know everyone thinks that's crazy and not fair. And I don't think it's fair either. We hate losing eggs, but it's actually something that none of us can prevent. It's not something that we can change. There's not something that you control. It's just kind of how women's bodies are built. So next slide. So for a lot of patients, they're always trying to think about, okay, so I've heard my fertility declines, but at what age, what age does it really matter? And so I think so many people are familiar with the age 35 and they just kind of feel like, okay, at 35, things just like jump, like fall off a cliff, right? But it's not that simple. So things actually in a woman's body start changing around the age of 27 slightly. And then we see greater changes at 32. And at 35, that is a big inflection point, but it's not the only point where things change. All right. You'll see bigger changes around 37, 38, and then again at 40. So at all of those time points, we see changes, and we see changes in both the quality and the quantity of the eggs. And so unfortunately, we lose eggs as we get older, and the quality of the eggs also goes down as we get older. And so we know from studies that actually 1 in 10 women under the age of 35 have something called premature low ovarian reserve. So that's a lower number of eggs than we would expect based on their age. Next slide. So when we think about eggs, it's not just about numbers, it's also about the quality of the eggs. And the easiest way to kind of wrap your head around it is to think about the fact that the eggs were put in your ovaries, right? If I'm talking to women, for men, they don't have ovaries, but for women, the eggs are put in the ovaries before they were born, right? And they're not fully developed. So they go through their final stages of development around the time that they're being released from the ovary and it's their time that they're being fertilized by sperm. And so at that point in time, if that's happening and you're ovulating at the age of 35 or you're ovulating the age at 40, the little mechanical parts that are driving, all right, the development of those eggs, they just don't work as well. It's like if you have a phone or a computer or a car, you may not turn it on for 10 years and all of a sudden you want to try to turn it on. It's not going to turn on all the time. It's just not going to work great. And so that same thing is happening with our eggs. Those little mechanical parts aren't working so well all the time. And so sometimes that's going to lead to an egg that just can't become a baby. Next slide. So when we start thinking about, when you need to be thinking about the quality of your eggs, the number of eggs that you have, the reality is that there actually isn't too early of a time to start just thinking about it. You can be really proactive about your healthcare. I think it's one of those questions. I was actually just talking with a patient yesterday about this, and she said, gosh, they're spent so much time telling me how to not get pregnant, right? When I was in high school. And I said, yeah, they did spend a lot of time doing that. And you know what? They also spent a lot of time when you were probably in 5th grade learning about your body. But then no one reminds you about this stuff in your 20s and your 30s. All right. And so it's just important to learn the information about your body so that you can be proactive and take steps to think about and reaching for you what your ideal family is, because this is all about having your ideal family. Next slide. So when is it that women are the most fertile? So if you think about their a menstrual cycle, right? So from one time that you get your period in 1 month, and let's say January, because that's up on the screen, and then to the next month, February, many women have 28-day cycles. If you have a shorter cycle every 21 days or a longer cycle every 35 days, that's actually totally fine. If it's shorter, way shorter than 21, if it's longer than 35, that's when we start thinking that there are issues. And it's also okay if your periods are not exactly the same interval every single month. Like if it's 25 one month and then 28 the next month and then 32 another month, that's also okay as long as it's within that time frame. It does make it a little bit harder to think about the perfect time to try to get pregnant. It's a little bit easier if that interval is all the same. All right. So usually a woman is ovulating 2 weeks before she's going to get her period. So if she's having a 28-day cycle, that means she's ovulating around day 14. But if a woman's having a shorter cycle, let's say it's a 21-day cycle, that means she's ovulating as early as day 7. And so that's really important to understand what your fertile days are. And so if you don't understand it, talking to a provider, coming into a Kindbody office, and just even having really an informational session about, okay, what can I do to kind of optimize my natural chances of getting pregnant? We're happy to help with that. All right. And we can kind of pinpoint that window, which is about 4 to 5 days, right around the time of ovulation, when it's best to start trying. Next slide. So one of the other things that we think about with women is kind of estimating exactly kind of what I was talking about before, which is the quality and quantity of your eggs, right? Now, the secret is that we don't really need to do a lot of tests to understand the quality of a woman's eggs, because a woman's age is probably the very most important factor that drives really the vast majority of what controls the quality of the eggs. Because remember, how old you are determines the little mechanical parts in the eggs that are controlling their development, right? And so for women who are 30, right, their ability to get pregnant and chances that they're going to get pregnant per month are very tightly controlled around that age, which is different than 35 and which is different than 40. Where we tend to see a lot more variability is what's called ovarian reserve. And that's the number of eggs that a woman has. And we can estimate those by doing a blood test and also an ultrasound. So the easiest and most consistent blood test is a test called AMH. It can be run anytime, so it doesn't matter where you are in your menstrual cycle. It doesn't even matter if you have regular cycles. We can get other hormones, but AMH is usually the most consistent one because it doesn't matter where you are in your cycle. And that can let us know kind of both how many eggs we think you're going to have, what we think is going to happen in the next couple of years in terms of your ovarian reserve, and also how your body is responding to hormones. In addition to getting the blood work, we can get an internal ultrasound that lets us count something called follicles. Follicles are just the fluid-filled sacs that contain the eggs in your ovaries. And what it allows us to see is how many follicles your body is recruiting each month, right? Because what ends up happening is each month you have a group of follicles, right? And remember, a follicle just has an egg in it. So there's a group of eggs that are bubbling to the surface of the ovary, right? And there's a whole group. And then of those, one of the eggs is chosen to ovulate. It's actually not the best one, it's random. And then the rest of the eggs in that group, if they're not chosen, they shrivel up and they die. And that's actually how we lose all of those eggs each month. All right. Now, the size of that ovarian reserve is really helpful because that can help us determine what treatments we might be able to use for you in terms of both fertility preservation and infertility treatments. And so understanding what your follicle count and AMH helps us kind of figure out, all right, what is your timeline? What do we need to be thinking about now, 2 years from now, 5 years from now, and even 10 years from now? Next slide. All right. And so I think I talked a little bit about this already. And if you do your testing with us, you can see all of your results in your portal where it's super clear and transparent. This is what your AMH is, a reminder of what that means for you, because I know it's so hard. I know it's the same for me when I go to a doctor's appointment. I'm listening. I feel like I remember everything. You walk out of that office and you kind of forget everything. Well, we want to make sure you have all that access, information accessible to you. And so you'll have a really great patient portal that has all of this information that will kind of remind you what is a follicle count and what does that AMH level mean. All right, next slide. So we also need to evaluate sperm. Remember, so sperm is also one of those really important building blocks. And so for the sperm, the way we evaluate it is we do something called a semen analysis, right? And that's where we get a sample and we look at it in the lab. And what we're looking at is how many sperm there are, how well they're moving, all right, and then the shape of the sperm. And then there's other factors that we look at in the semen analysis as well. We typically do a semen analysis 2 to 5 days after the last ejaculation so that we can get the most, I think, informative sample. All right. And so the total number of sperm and how well they're moving really affects how easily the sperm can get up to the egg if you have a heterosexual couple that's having intercourse. Right. The shape of the sperm is really important because the shape of the sperm tells us, okay, once the sperm is up at the egg, how well can that sperm actually get into the egg? So can it fertilize it once it's there? And so you can see all those pictures. There's lots of different ways that the sperm can look. And in fact, actually, there are very commonly and most often way more abnormal looking sperm than normal sperm. So that's something that we're going to look at as part of a normal evaluation. All right, next slide. So we also want to make sure that someone's uterus looks okay and their fallopian tubes are okay, right? So the uterus, it's just a big muscle. You can see a picture of it there. And that triangular black little triangle at the top, that's actually the uterine cavity. That's the space where the baby grows. And so we have different tests that we can perform for couples who are having a hard time getting pregnant, right? That can tell us, okay, is this shape normal? Is there scar tissue inside of the uterine cavity? Maybe they've had surgery before. Women often have these not cancerous lesions inside the uterus. And so we'll look for those. We'll also make sure the fallopian tubes are open because the fallopian tubes, those are the little arms coming out of the uterus that go and grab the egg once you ovulate it. And so then the egg actually hangs out in the fallopian tube and that's where we meet the sperm. And so it's really important to evaluate those things. Next slide. There are lots of other factors besides those main things that we evaluate. So our bodies really as a whole really can affect our reproductive health. And so thinking about and understanding when we talk to our patients what their everyday routines are, what the environment is that they live in, all of these factors are important, right? We think about diet, lifestyle, family history, your mental health, all of those things are important and can impact your fertility. One of the most important things that I always feel like is a question that a lot of my patients have is birth control. So a lot of patients are on oral contraceptives or they have IUDs and they get very nervous that they are on them for a really long time, that it's going to negatively affect their chances of getting pregnant. And the answer actually is no. So you can be on birth control pills, for 20 years and it is not going to negatively affect your ability to get pregnant. Next slide. So how often is it that a couple can't get pregnant? And so we have general numbers. So we know that 1 in 8 couples will experience infertility. And we know that a third of the time it's due to a male issue. I would say the vast majority of the time, there are a couple of things going on. It's not just one thing. So there might be an issue with the egg. It might be something with the uterus or also something on the male side. So there can be multiple things going on. About 15 to 20% of the time, we don't find anything, all right? But it is also important to know that as you get older, it gets harder to get pregnant. And that's because of that quality issue that we were talking about a little bit earlier. So if we look at the chance of getting pregnant per month, if you have a heterosexual couple, they're trying to have intercourse at home, at the age of 30, your chances of getting pregnant is about 20 to 25% per month in those first few months you try. And by the age of 35, that number is down to 15%. By 37, it's 10%. And at 40, it's 5%. So your age is really important in terms of just thinking about how hard or how easy it is to get pregnant. And so that is why we always recommend, if you're 35, right, that you should start a workup and start having fertility treatments earlier. So under the age of 35, you can try for up to a year. But if you're 35 or older, we don't really want you trying for more than 6 months before we start doing a workup and then also doing fertility treatments. I will also say, I think that information is extremely powerful and important. And I have lots of patients that will come to me that want to have a fertility treatment, even if they've only tried for 1 month, right? It can be really stressful trying to get pregnant. And sometimes couples really just want to know things are okay. It will allow them to relax a little bit and say, okay, I've checked everything out, things are good. So I can just try and get pregnant in 6 months. And if in 6 months things aren't okay, then I'll come back to Dr. Bendikson and we can talk about next steps. Next slide. So, what can you do in terms of, when you want to get pregnant? So one of the things you can do is just have a consultation with a fertility specialist like me, right? And we'll talk to you about all of those things, your lifestyle, your medical history, what are things that are important for you in terms of your goals? Like, what are your family planning goals? Right. And then based on that and based on any workup that we decide to do together, what you feel comfortable with and what we recommend, then we can make a personalized plan for you. Every couple is different. And I think it's so important. And we all here at Kindbody, we really believe that our job is so important to give you information. And then you have to be part of that process of deciding what the next steps are. This is your journey, and we're here to help you upon that journey. Next slide. It's also important to remember that the path to parenthood is not the same for every couple. And so we have to be here to support you in every step of that journey. And sometimes the journey is different because you're just starting out with different needs, right? Maybe you need to use a sperm donor, right? And so that journey is going to look different than for a couple that can have sex at home to try to get pregnant. And sometimes your journey is different based on what happens, right? Sometimes it's easy to get pregnant, but then sometimes it's really hard and it takes a long time. And then sometimes you can get pregnant, but you can't stay pregnant because you're having lots of miscarriages. And so that path to having your family can look really different. And so your needs are different. And so we always want to make sure that we support you every step of the way. Next slide. So you have lots of options in terms of thinking about what those fertility treatments are. You can think about fertility preservation. So this is thinking about not only the now, but thinking about the future. Do you want to freeze eggs? Do you want to freeze embryos? Right? You can be struggling getting pregnant and you can make a decision about having a fertility treatment that's very focused on having one baby right now, like doing an IUI, that's an intrauterine insemination where we put the sperm at the top of the uterus. Or you can opt for potentially embryo freezing. So we do essentially an IVF cycle, take eggs out, fertilize them with sperm, and create embryos, and then use them to help get you pregnant now, but also have embryos stored for you in the future. Or it may be that you need help from in another direction because you need an egg donor or a sperm donor, or you need someone to help carry your pregnancy for you. So let's talk about some of these different types of treatments in a little bit more detail. Next slide, I think we'll start with egg freezing. So what is egg freezing? So egg freezing is the process of where we stimulate the ovaries to make eggs, right? And then we take those eggs out and then we freeze them so that you can use them at another time. And this works because we can take the eggs out, and let's say we do an egg freezing cycle when you're 30. That means that you have 30-year-old eggs frozen for you for the future. And kind of the secret in all of this is that the uterus doesn't age, right? So your ability to get pregnant from your uterus, like your uterus's ability to carry your pregnancy, is the same at 30, 35, 40, 45, even 50. You can be menopausal and 52 years old and carry a pregnancy. Because if you froze your eggs at 30, you could be 52, no longer having periods. You don't have any more eggs left. We can unthaw your eggs, and your chance of getting pregnant at 52 is that of your 30-year-old self, because we froze your eggs at 30. That's incredible. And it is truly like kind of pressing pause a little bit. All right. So next slide. So with egg freezing, it's always really important to ask yourself in terms of thinking if it's the right decision for you, is how old are you now? Right. And so, okay, so let's say you're 30 or 35, that may influence your decision to freeze eggs. How many kids do you want in your ideal family? Maybe you're 30, but you have no interest in having kids until you're 38, but you want 3 of them. So that's going to be problematic if you don't wait, if you wait till you're 38 to have your first child, because guess what? Pregnancy takes a year. And then the healthiest pregnancies happen 1 year after a baby's born. So if you're having your first pregnancy at 38, that means your second one's going to be at 40 and your third one's going to be at 42. So you have to think about, all right, not only how old you are now, how many kids do you want, but how old do you want to be when you have your first child? And then how old do you want to be when you want to have your last child? And almost in some ways, kind of plan it out. You never know, your plans are going to change. But in this moment in time, what are you thinking about for you? Next slide. So as we talked about before, each month the ovary recruits a group of eggs that are bubbling to the surface. All right. So when I'm helping someone freeze their eggs, I can't actually make them have more eggs than are already there. We actually can only work with the eggs that are naturally bubbling to the surface that month for that woman. So that's why doing that ultrasound and assessing that follicle count becomes really important when you're thinking about egg freezing or even IVF, because that's what we're working with. And the good news is that you have a group of eggs that are there. So instead of just, your brain's really smart. Normally your brain sends a little bit of this tiny hormone to make one egg grow. All we do in an egg freezing cycle is give you a lot of that same hormone. All right. You're going to just take it through tiny shots, right? And that's going to make as many of those eggs grow as possible. And if you remember what I told you before, in that group of eggs that's growing, one egg is going to ovulate and the other eggs, they show up and they die each month, right? And so if we do egg freezing and instead of letting those extra eggs die, we're going to stimulate them and grow them and take them out and freeze them and save them for you, we don't change your fertility in a negative way at all, because you would be losing this whole group of eggs anyway. We're actually just kind of capitalizing on the fact that there's a group there, and we're going to take advantage of that. Next slide. All right. So it really is just that taking advantage of what your body is allowing us to do anyway, which is really opportunistic and very helpful. So how do these hormones work? Next slide. So what ends up happening is that we actually, because we're giving you hormones instead of actually you just kind of having your brain give yourself, your brain is normally sending the hormones down. That process to have an egg develop takes about 10 days. So you're going to be taking a couple shots at each night, right? So usually it's around 2, and they're tiny little shots that go right under the skin. Our nurses teach you how to do them, right? And during that interval, we monitor you for about 4 to 5 visits, right? Because we want to see how you're doing. Do we need to adjust the medications, and when we're going to actually do the egg retrieval? So we make this process as smooth as possible. And if you can go to the next slide, I'll show you what a calendar looks like. So it ends up being really fast. So let's look at this calendar here. This person, she's going to start her medications on a Friday. And if you can see, she starts on a Friday. She's going to have about 3 to 4 visits in the office, like the following week, like Monday, Wednesday, Friday. And then she's going to have her egg retrieval somewhere probably between Monday, Tuesday, or Wednesday of the following week. So it's really fast. It's not a really long time. All right. Next slide. And so once you're actually done with the shots and you're ready for the egg retrieval, this is a really quick procedure. It takes about 10 to 15 minutes. You're under some very, it's not local anesthesia, but it's what we call twilight anesthesia. So it goes through an IV line in your arm, and you're not awake, you're not aware of anything, you're not in pain. All right. But at the same time, you're breathing on your own. This is not general anesthesia. And we can just do it in our office, and it's really quick. And then you wake up right after the procedure and you're ready to leave our office. And our patients are walking out of our office about 45 minutes after the procedure is completed. And they usually just need Tylenol and Advil that day because they just have a little bit of cramping. Next slide. So egg freezing is really great because you don't have to choose a sperm source at that time, right? And so it allows you to freeze eggs that are just yours. And obviously, our hope is that you probably maybe don't ever use these eggs, or if you're going to have to use these eggs, you're using them for a third baby, right? Or maybe just the second baby. Maybe you get pregnant on your own the first time. When you're ready to get pregnant after you've frozen your eggs, you don't have to use your eggs to get pregnant. You can absolutely try on your own, right? And so that's where, again, we come in. Like when you're ready to get pregnant, you come back, you meet with us, we figure out, we make a plan, and then we decide at a later point, do we want to use your eggs to help you get pregnant if you need them, right? And the beauty is that the eggs last a really long time. All right. They can be stored indefinitely. So you can freeze them when you're 30 and you can use them theoretically when you're 50, which is really incredible. All right, next slide. So what is IVF? So IVF, all right, is in vitro fertilization. And so IVF is actually the first part of it. The stimulation portion is exactly the same as egg freezing. All right. So we take those eggs out with an egg retrieval. The difference is what we do on the back end. So if we're freezing eggs on the day of the egg retrieval, we take the eggs and we freeze anything that's mature. If we're doing IVF, we're going to fertilize those eggs. And so we get sperm that day, right? And then we take the sperm and we actually most commonly inject the sperm directly into the egg, or we can place the sperm around the egg, and we're going to fertilize it and then make an embryo. And at that point, we have lots of different options. We can transfer an embryo right in, 5 days after the egg retrieval. We can freeze the embryos. We can also do genetic testing. So we can actually test the embryos to see if they are what we call chromosomally normal. So do they have the right components of the genetics that's going to, hopefully, when they're normal, lead to a pregnancy? But if it's abnormal, that was what could lead to you not getting pregnant, having a miscarriage, or having a pregnancy with an issue like Down syndrome. And so we can identify those things in the embryo before we put the embryos back in. Next slide. So what about reproduction versus third party? And I'll say the word third party because that's a term that so many people are familiar with. At Kindbody, we like to call it family building, right? Because that's really what we're doing, all right? But sometimes when you're building your family, right, it requires the use of an egg donor. It requires the use of a sperm donor, or you need someone to carry a pregnancy. And so we can handle all of those different situations. Next slide. It's really important when you're thinking about selecting a donor, right? Sometimes you don't have a sperm donor or an egg donor that you know, and so you're going to use an agency, all right? And an agency will help you find a sperm donor or will help you find an egg donor. But sometimes you have someone in your life who wants to donate their sperm or their eggs to you, and that's okay too. And we will help you whatever it is that your choice is. If you are using egg donor, so with egg donors, you have an additional option. You can actually purchase frozen eggs, so eggs that have already been frozen, or you can have a donor go through a cycle for you. So essentially just going through what we just talked about with the stimulation with egg freezing, they go through that process and all of those eggs from that cycle then belong to you. Next slide. So for some women, they can't carry a pregnancy on their own. And if you have a gay couple, they'll need a uterus. And so they'll need someone to carry the pregnancy for them. All right. And so sometimes you need to get someone, and we call that a gestational carrier or a surrogate, and that's someone that's going to carry your pregnancy. Sometimes you might be making the eggs, but you're not going to carry the pregnancy. So for example, in a lesbian couple, we have something called reciprocal IVF, where one of the partners, she's going to provide the eggs. So she goes through stimulation, we get the eggs, and then we use whatever sperm source they want. And then the other partner is actually going to carry the pregnancy. So that's called reciprocal IVF. All right. And so we do all of that and we help all of our patients go through this process because there are so many decisions and it can seem really daunting and we don't want it to feel that way. We know that there are important decisions that you need to make and we want to make you feel supported and kind of guide you through that process. So we have our own team, our own family building team that does that. Next slide. So really at the end of the day, there's just, again, not a perfect path and there's not one path to kind of creating your family. And so the most important thing for you is to be educated, to be well informed, so that you can make the decisions that are right for you. And also kind of know where you stand, understand what's going on with your fertility and how that's based on your age, all right? And kind of where you want to be and what you want in your ideal family. Next slide. So other treatment options that we have is we have IUIs, all right? So IUIs are intrauterine inseminations. And so that's where a woman is going to ovulate on her own, all right? And then we either will use her partner's sperm or a donor sperm, and we take that sperm and we place it at the top of the uterus. Right? Sometimes we're doing IUIs and natural cycles, maybe just because there's a sperm issue and we need to kind of boost the number of sperm they're getting up to the egg, but we don't need to increase the number of eggs that are ovulating. Sometimes we do something called an ovulation induction. This is actually where we give the woman maybe about 5 days of an oral medication that's going to make her ovulate 2 to 3 eggs, right? So we're going to boost her odds of getting pregnant a little bit. All right. And then we're going to improve fertilization a little bit by getting the sperm closer to the egg. It's not as powerful as IVF, but it is sometimes a really good option for some patients. Next slide. So let's talk a little bit about Kindbody 360. And I'm really just so proud to talk about this service and services that we provide here. So I don't know if you guys are aware, but it can be really hard when you're not getting pregnant. And we know that 90% of those who have infertility do experience some type of depression. And it's even as high as 42% might have some thoughts of suicide. That means it's stressful. It is very stressful, and women can have the same level of anxiety and depression as they can, and what we see, right, and studies with cancer, heart disease, and HIV. That's powerful, and it's so important to recognize, right? Next slide. And so there is a need for support, and there's a need to kind of maintain a sense of well-being and balance as you're going through those fertility treatments. And so I think for every couple and every person, what that support is different. And sometimes it's friends, sometimes it's family, and sometimes you just need help outside of those two possibilities. And so that's why we, provide licensed therapists that can really help you and guide you along the way, because these are therapists that are specialized and they know what the treatments are. And so I have lots of patients that might do talk therapy with their own therapists, and some of those therapists are well versed in some of these fertility treatments. But sometimes my patients just need a little bit something extra right in the middle of the treatment, just to kind of, maybe they've had a negative pregnancy test to bridge them to the next treatment, or just kind of throughout. And so it's so nice that we can offer these additional sessions for our patients. Next slide. And so our therapists can help in many different respects. Sometimes it's just the stress from going through fertility treatments. It can also be the grief that a couple experiences after a miscarriage or a failed transfer. There's very good data to suggest that women who have miscarriages can have the same level of grief and experience the same level of trauma as someone who's lost a child. And so it's so important that we recognize all of these challenges that different couples go through. Let's say they're going through just the process of trying to find a donor egg. And so that process of wrapping their head around of getting to a place of serenity, of kind of accepting this is what your path is. Sometimes you can accept it on one level, but you need help as you're kind of going through the process. And those are kind of the things that our therapists can help you with. So it's whatever and wherever you are in your journey, they can meet you at that place and help you in your path. Next slide. And I do think it's just so important. And I'm so glad that all of you are here because it is just so important to talk about this. Um, I had lots of different patient consults yesterday, and one of my consult was a woman who was thinking about freezing her eggs, and she's in her 40s, and she, at some point had talked to an OBGYN, and they had said, "Oh, you have time, you have time," and she said, "I never talked about it with my friends." She's like, and now my friends are talking about it, but now I'm 40. I wish I had done something earlier. I wish that people talked about this, and more. And I said, yes, absolutely. And that is what we're trying to do at Kindbody, is open that conversation, talk about reproduction, talk about fertility, so that people can understand it and make better choices for themselves, whatever those choices may be. All right, next slide. So it's really important for us to help you think about kind of what your goals are, when you're trying to think about getting pregnant, whether that's now, it's tomorrow, it's 10 years from now. Just learning the basics and understanding how age can influence those reproductive choices, how age can influence fertility treatments is so incredibly important. Next slide. So where can you find us? And you can find us all over, which is, again, as we started this Fertility 101 session, it was just so fun to see people from all over the country, because I think that we have Kindbody clinics near most of the locations where people were hailing from. And if we don't have a Kindbody clinic, we have partner clinics that we work with for those patients who have our Kindbody insurance. But we would love to see you, and we are opening more clinics as well. So if you don't have a Kindbody clinic near you, the chances are that we'll probably be opening one near you in the near future. Next slide. All right, so I guess we have a special promo. So if you use the code OCT, which is, I'm assuming, October 22 101. This is for our self-pay patient, and it's good through November 15th, 2022. So we're offering a complimentary virtual fertility consultation for those patients who are interested in pursuing treatment. And so it's really easy to schedule. You can just go to our website at kindbody.com. /location -select / and then you can put in that promo code and get that free virtual fertility consultation. That is really amazing, guys. I didn't even really know that we were doing that. Go Kindbody. I love it. So hopefully everyone on this call will be able to take advantage of that. Next slide. All right, I guess this is our time for questions and answers. And I've been so focused on my slides that I've been seeing all of these questions come in the chat. And so I'm not sure which of those questions that you guys got to already. And we have enough time that we can definitely go through them.
Thank you. Thank you, Dr. Bendikson. We really appreciate it for such an informative presentation. So we do have a few questions that have been submitted, as you said. Some of them have been answered by Mia, but we have a few that haven't. So let's start with this one. What are the chances of a successful pregnancy via IVF after 40?
That is such a great question. And it very much depends, all right, on the number of eggs that we can get in one cycle. So this is where that follicle count and the AMH become extremely important, all right? Because ultimately, if we have an embryo and we've taken that embryo and we've tested it and it has the normal amount of chromosomes, it doesn't matter if you are 40 or if you are 36, the chance of that embryo becoming a pregnancy is the same or very close, all right? So if we have a really nice quality embryo, you could be 44 and your chances of getting pregnant if we put that embryo in are 70%. The biggest issue that comes as a woman gets older, right, is that a woman is starting out with less follicles and their AMH is lower. So that means that they may not be as responsive to the medications. And so in one round of IVF, right, they will get less eggs. And if they have less eggs, that means we're not going to have as many embryos, right? Because they're not all going to fertilize. And not all of the embryos grow to and develop to the stage where we can actually transfer an embryo back in, right? And so really knowing what the follicle count is what's going to drive the chances of getting pregnant. Because if a woman is 44 and she only has 4 follicles, then the likelihood that we're going to be able to get 4 eggs is probably not so high. Realistically, we're getting 2 eggs, and if we get 2 eggs, we might have 1 embryo, and then maybe it's only a 30% chance that we're going to have an embryo that we'll actually be able to use. And so I think that's why it's so important to always have information and have a follicle count, have an AMH done, talk to a provider so that they can give you specific information. Because I have patients, I just saw a woman this week who's 42 who has over 20 eggs, right? So she can go through the process and she's going to have a lot more eggs. That's not as common, just so you know, for a woman who's 42, but she's going to have lots more opportunities to get pregnant from one round of IVF to get to that 1 embryo that we can actually transfer in and become a pregnancy.
Thank you. And we have another question here. How do fibroids affect egg retrieval and egg freezing?
So it depends. Most of the time, fibroids do not affect an egg retrieval. The only time that they do is when the uterus is so big, because the fibroids are so big that it has pushed the ovary so far out of view that we can't get it. So the way the egg retrieval works is the ovaries are right up against the vaginal sidewall. And so the needle goes right through the vaginal sidewall directly into the ovary. And so if the ovaries push very far to the side, then it's going to be too challenging to get it. Now, the interesting thing is sometimes it's not just about size of the fibroid, it's the location, because I've had patients that have had 10-centimeter fibroids and their egg retrievals are super easy because it's just like the location of the fibroid isn't affecting the ovaries and where they are up against the vaginal wall. And I've had other situations where I've had a 6-centimeter fibroid that happens to be pushing the ovary really far away, and it can make it very challenging. And sometimes, we'll be very honest with you when you're going through the process. Sometimes it's really hard to see the ovary and it might be challenging as we're going through the monitoring process, but all of a sudden, once the patient is asleep and everything is relaxed, it's super easy to get to the ovary. So your provider should always be giving you that information about how easy or hard we think it's going to be to get to the ovary at the time of the egg retrieval.
Thank you. And another question we have here is, what is a normal AMH range at age 35?
Okay, that's a great question. So AMH, I like to think of AMH as in buckets, all right? It's either high normal, it's in the middle, or it's low, all right? Part of that is that the AMH assay is not so sensitive and precise, all right? So you could have your AMH drawn on Monday and the result will be 1.2, and you could have it drawn on Friday and it's going to be 1.7. Right. And then you might get super stressed out because it's like fluctuating so much, but in reality, it's just not fluctuating. The assay is just that precise every time. And so that's why we really lump it into buckets of like, normal, medium, and then low. And then sometimes we have like super high. So super high can sometimes be associated with a syndrome called polycystic ovarian syndrome. So if you have a really high AMH, let's say 6 or higher, sometimes that's related to PCOS, but I have lots of patients who have regular periods who do not have PCOS and just happen to have lots of eggs and therefore higher AMH levels. When the AMH drops below maybe 2.5, then it will potentially impact the response to stimulation. So that's just something that's important. So I kind of think of that maybe 1.2, 1.5 to 2.5 is kind of being the middle range. Once the AMH drops below 1.2 and even 1.5, then the response is pretty similar. And that's kind of the lowest bucket. So in my mind, it doesn't matter if someone's AMH is 0.4 or 0.8, the ovary is going to respond the same in a stimulation. At 35, there's not, because AMH is reflective of not only like how well the ovaries are responding, but also quantity, there is going to be a pretty wide variation in what the AMH is. At 35, you're not going to have as many women that have really low AMHs, like less than 1. Whereas if you have someone who's 42, I pretty much expect their AMH to be less than 1. That's pretty routine.
Thank you. And another question we have here is, can someone still do the AMH and antral follicle count if they're currently on birth control, specifically the NuvaRing, rather than the pill or IUD?
That's a great question, because we know from very good data from hormonal contraception, so taking the oral contraceptive pill, that the AMH and the follicle count will often look lower while a woman is on hormonal contraceptives. It's not actually lower. And so we know that if you take them off of oral contraceptives, right, that 60% of women are going to have a bump of 50%. All right. So that's pretty big. So you can go from like 10 to 15, right, with just like 2 months off of oral contraceptives. And that's the same. And the NuvaRing is essentially the same thing. So the impact will be the same. And we sometimes also see that anecdotally with the Mirena IUD, because it has progesterone in it. I always encourage my patients to get a baseline. So I would never say, don't get an AMH, don't get a follicle count because you're on oral contraceptives, it's not worthwhile. Always get it, because there are some women where things look totally fine, even though they've been on the birth control pill or the NuvaRing for 10 years, right? So it's always a good idea to get checked and then speak with a provider and make a plan, right? If you're trying to do egg freezing, do you need to get off? I mean, if your AMH and follicle count are amazing, then maybe you don't need to get off of it before doing an egg freezing cycle. But if it's kind of in the middle range or lower range, you might want to think about getting off, if that's something that you can do, because you have to think about the birth control that you're not going to have anymore for a month or 2 before doing a cycle.
Thank you. And we have someone else who wrote in, hi, I'm 30 and I've gone through IUI and it was not successful. I know that my last blood work indicated that I have a low egg count for my age. I'm wondering if it's possible to figure out the quality of the eggs I do have and if IVF is possible.
Well, I'm so sorry that you're going through that. I know that can be really hard. So remember, the quality of someone's eggs is mostly determined by how old you are. All right. And so sometimes when you're young, you can have good quality eggs. And even with good quality eggs, you might not get pregnant with IUIs, because IUIs help a little bit, right? But they're not as effective as IVF, right? And so when you have low numbers, all right, you can absolutely still go through IVF. And the powerful thing is, if you are young, your egg quality is going to be better. So you're more likely going to end up with an embryo that you can transfer in, and an embryo that would lead to a pregnancy. So absolutely, even when you have low ovarian reserve, IVF is absolutely an option for you.
Thank you. And we have another question here relating to low ovarian reserve. They said, for someone who has low AMH levels and an irregular menstrual cycle, but doesn't want to get pregnant yet, does egg freezing make the most sense, or are there better / less expensive options?
I think that it really depends on what your goals are, right? So in a situation where you are not ready to get pregnant, then egg freezing really is the only option, right? To preserve your ability to get pregnant. The alternative is just to wait until you're ready. And then I think when someone has irregular periods, it's really important to understand why they're having irregular periods. That can happen for so many different reasons. It can be polycystic ovarian syndrome, which is more commonly associated with like a high number of eggs. Sometimes it's because women are going through that perimenopausal stage, right? So they may be young, right? But their periods aren't as regular. And sometimes they're ovulating, sometimes they're not, and that can kind of be a scary time, because that period of time, the perimenopausal time, can last a year, can last 5 years, 6 years, right? And so a lot of what you do really just depends on what your goals are. But the only way to preserve eggs is doing egg freezing or embryo freezing, if you want to freeze as embryos.
Thank you. And we have another question here. What is the typical timeline from consultation to embryo transfer for IVF with genetic testing?
So it takes about 2 months from the beginning of a cycle, right? So if you think about it, the stimulation cycle itself is 2 weeks, right? And then if you're, we have to grow the embryos out for another week. So that's 3 weeks, right? And then if we're testing the embryos, we'll get the results 2 weeks later. So that's 5 weeks. And then when you're doing a transfer, it takes about 3 weeks to get your uterus ready and do the transfer. So that's 8 weeks right there. So that's 2 months, right? And then if you're adding on the time for a consult, right? Realistically, we could do a consult and then we could start someone within a couple of weeks to do an IVF cycle. But one of the biggest barriers that we have is doing something called genetic carrier screening, which is incredibly important. And that's looking for mutations in your DNA that you could pass on to your children. And unfortunately, those results take 2 to 3 weeks to get the results back. And so that ends up being from the time of a consultation to the time you're starting your IVF cycle. Oftentimes, the genetic carrier screening might be the thing that is really kind of, we're just like waiting on those results before we can start the cycle. Because if for some reason now we're having to screen the embryos, not just only to see if they have the correct number of chromosomes in DNA, but we're having to screen it for a disease. Sometimes in order to create the probe so the companies can test the disease, test the embryo for specific disease, it can take 2 months to create that probe. So it can add on time if we're having to do that in addition to just the regular testing.
Thank you. And we're almost at time here, so we'll take just one more question. What is better for a woman after tubal ligation, IVF or IUI?
So if you've had your tubes tied, then IUI is not an option, right? Because in order to get pregnant, the ovaries release an egg, the fallopian tube has to go grab the egg travels up the fallopian tubes and hangs out there, right, for the sperm. And then the sperm makes its way from the vagina through the cervix up to the egg. And so if the tubes are tied, that's not going to work. All right. And most of the time, the surgeries where we can reconstruct a tube are not very effective. They can increase a chance of a tubal pregnancy in the future. So in those scenarios, IVF is a better option.
Thank you, Dr. Bendikson, for so much information that you've provided us today. And thank you to everyone who joined us tonight. If we didn't get to answer your question, please email it to us at navigator@kindbody.com so we can get that answered for you. Or feel free to reach out to us on Instagram at Kindbody. Have a great evening, everyone, and thanks again for joining us.
All right, everyone, thank you so much for coming. Thank you for your fantastic questions. And I'm on Instagram too. Always feel free to reach out to me. If you're in Los Angeles, I'd be more than happy to see you. But I know you guys are from all over the country. And if you decide to go to a Kindbody, you'll have an incredible provider at the clinic that's waiting for you.
Thank you.
Thank you.
Have a good night, everybody.
Bye. Thanks.
Thank you.
Bye.
Have a good evening. Have a good night. Thank you all.